This conference will now be recorded.
So forgive me, I forgot to start the recording at the beginning, but that's not a.
That would have been a good recording to send my sister.
Yeah, it would have been great for your sister to have listened to that, and I'm so sorry that I forgot to do it. And thanks, I think Jake reminded me. I want to say just a couple of things, and then I'd like Ken Anderson, and then maybe we'll just wrap it up with a couple of suggestions for you, Ted.
Okay.
You know, the fact that your doctor, your urologist, never did a CT scan or a bone scan before he did the radical prostatectomy would be a real concern to me, because it's so basic. It's such standard protocol that it says to me, these guys aren't on the ball where you went. That's how I would respond. And the issue is that through that they may have seen possibly a metastatic lymph node, or they may have seen some metastasis beyond that, and you would have made a decision for treatment with that knowledge, and they never gave you the opportunity to do that. And that is a great concern to me. So I personally, if I had any choice and I could go somewhere else, even within Austin, I would probably do that at this point in time.
Mm-hmm.
Now, if you can get to MD Anderson, that would be dynamite. If nothing else, they can guide you and navigate you, and you can get your treatment in Austin.
Okay.
But they can be your quarterback, if you like. And that's essentially what Jim does, and essentially what Ken Anderson does. Both these guys, Ken and Jim, are under 60. Both of them are prospectively great mentors for you. And you've taken the first step, which is to join us, which is a big step on your part. I know that. But we'd really like to see if we can help you, to guide you to get the best treatment, so that we can, put this into long-term remission. Ken, would you like to add anything to what Jim said?
Yeah, I can. Both Peter and Jim were spot on. Must say, Ted, you're not going to die like today or tomorrow or 5 years from now or possibly even 10 years from now. I mean, we all go through phases, and I'm going through one right now where my PSA has risen when it was expected to go down, and it has made me a little mental. And I use the word mental when I get crazy about the disease, not necessarily progression, because I don't think it's progressing a great deal, although my PSA has risen and I've been dealing with it for 3 years. I didn't catch, how old are you, Tad?
52. I'll be 53 next month.
Yeah, you're young. How is your insurance?
I'm on SSI. That's the only way I got Medicaid.
So you have Medicaid. I'm not sure how that works with MD Anderson, but
Yeah,
I
I
would
did
imagine.
check with them, and they do take it. I just wouldn't. I guess that's kind of like two final questions. You can just put it in any time you want. Is like, just how would I start? Contacting them or start with them, and then also, what should I discuss with this oncologist on Thursday? Not doing our next meeting. That's about all
Oh,
my
I didn't catch all that. How would you start? How would you start is I would send Paul a message once I get your full name and see what he has to say. I do believe he's still taking patients. So he's not in, I think he's traveling right now because I had sent him a message and I got a reply back that he's not even around. He's a real good and compassionate, very, very considerate in regards to one's state of mind at the time of diagnosis. Just a matter of getting you to MD Anderson, I guess. I would probably try to go there and use them if at all possible as your quarterback. But again, if not, then find someone closer. you know, I would strongly encourage it. So I didn't catch the balance of your statement as far as what you were looking for, though. If you could repeat it, I'd appreciate it.
Yeah, well, that was the first part. Just how would I get started at MD Anderson? The second part is since I do have this appointment on Thursday with this oncologist, it's kind of like if there's any questions I should be asking him and such, and just kind of what should I be doing between now and our next meeting here?
I gotcha. You can either send, or we can send you the questions for the local oncologist. We don't need to like address it here. We can do it
Oh, great.
offline.
Okay.
Rick can send you, or I can give you my phone number or email address, or you can talk to either me or Jim Ward. We can kind of help you find your way. I
Okay.
mean, I understand freaking out. I do it all the time. I mean, I do. And at the moment, I'm not a good one to ask that question, or deal with that question because I'm pretty freaking out. But you'll be okay. So take a deep breath.
Yeah, so let me do this. I will be sure to connect you, Jim, and Ken after the call, and I'll include telephone numbers for Jim and for Ken. I don't have, obviously I don't have your. I may actually have your number, Tad. I think we might have spoken briefly.
Yeah, that was back when I was real upset about stuff. Apologize.
Yeah. So I'll look and see if I've got your telephone number, and if I do, I'll include it. But I think
give you a new one because they change a lot, and so I'll probably have a different one now from them.
Okay. If you get in touch and see if these guys can help you navigate, and then we'll try and figure out the logistics. There are some sources of help with transportation. If you need it, we can get into that. If you don't need it, then we won't go there. But there are various sources of transportation assistance. I think for the meeting that you've got coming up on Thursday, the biggest thing I would ask for before you do anything else is you need some scans.
Okay.
I mean, these guys haven't given you, they've taken your prostate out, you're a Gleason 9, and you have yet to have a CT or a bone scan. So I think the starting point is, let's get some scans done, and then we can talk about what we see on those scans and what the best option is. And we don't know that the best option is radiation. In the worst case, and I'm hoping this isn't the case, it might not be radiation. And they cannot.
Richard, you're saying he's had a radical prostatectomy already?
Yes.
Ah, I didn't know this.
Yes, they did a radical based on him being, do you know, Tad, if you were 4+3 or 3+4, you're 7?
Oh gosh, I don't know. I'd have to.
Okay, not to worry. It's not that important now. But they diagnosed Gleason 9s, and then they rushed him into a radical prostatectomy. And
I guess it was just the discussion. What I read online was, you could do, is it the radiation or the chemo, or one you can't do, after you do one or the other. And so that's why we did the surgery, because the other could follow. So that was
that's not strictly true. But the problem is you made the decision without holding a full hand of cards. And you needed more information before you made your decision, and you didn't have that information, and that's an issue. So I think the first thing you've got to do is go into the med-onc and say, we don't really need to have much of a discussion today beyond when are you going to schedule me for scans. Okay. And once you've done the scans, can we meet again, please? And that'll also buy us some time. But you have to take charge of this yourself. You're your best advocate here. Take somebody with you to the meeting if you can. If not, record the meeting. Okay. And tell them that you want to record the meeting and record the meeting. If they give you any pushback, they're definitely not the right doc.
Okay. Okay.
And in the meantime, between now and, did you say Thursday is your appointment?
Yes, sir.
You'll talk to Jim and you'll talk to Ken, and they'll help you along a little bit and navigate you.
Great.
Okay?
Really appreciate it. I really do.
It's a pleasure.
Good question. I'm sorry I came in late. What is your PSA now?
0.05.
Oh, all right. There was a recent clinical trial called Radicals that showed that and, waiting until PSA goes to 0.1, 0.1, or 3 consecutive rises is equivalent to getting salvage radiation uh, uh, without waiting. So you can is that your first PSA after radical prostatectomy?
Correct. 3 months after.
Oh, okay. So I guess I differ with some of these guys. I think that maybe you should be talking to a radiation oncologist and not a medical oncologist,
It's
and
really repeat, yes.
and perhaps based on the new learning from the Radicals clinical trial, you can wait at least another few months and get another PSA, see if the direction is increasing, see if it gets to 0.1, and if so, then you would need salvage radiation, and if not, you can possibly wait longer on it. The advantage of having salvage radiation sooner rather than later is that you may not need hormone therapy with it.
So the question I have, Alan, for you is, I do agree with you, and I had, it had slipped my mind, and I thank you for raising it. It's a really great point. But don't you think that we should at least have Tad ask for some scans? I mean, he's never been scanned, and he has Gleason 9.
Well, yeah, I think he should have gotten a bone scan with Gleason 9 before he ever got a radical prostatectomy. And certainly before he has salvage radiation, he should have a scan. And let's talk a little bit about what kind of scan. Before he goes in for salvage radiation, just to rule out that there are distant metastases.
Right,
I mean,
exactly.
that's the only purpose of it. Now, with your fairly low PSA, probably you don't have distant metastases. But I think Rick is absolutely right. It's something you need to check out at some point. Now, which point is a different matter, because there are some scans like the Axeman scan that are very good, but they won't show anything until your PSA gets to at least 0.2. And I don't think it's worth waiting for your PSA to go up that high before you have salvage radiation. Now, bone scan will almost certainly not show anything with PSA that low. Your PSA would have to be over 10 for a bone scan to show anything.
Yeah,
Now, was
Alan,
Yeah.
let me just say that that Tad's PSA was 21
Oh,
before he when he went in.
then
So
I agree with you completely. There's no, he absolutely should have had a bone scan with a PSA that high.
He
And
might have ordered it. I don't know. It was so difficult it's so difficult to talk to his office. I can never get through to anything. And I don't know. I've maybe heard something, but nothing was really pushed through or stressed to me or anything.
you know, I really do agree with Rick that a bone scan CT is a no-brainer. It's cheap. Medicaid will pay for it, it's quick. It's cheap. There's no reason not to get at least that.
Okay.
yeah, I mean, Tad, I would say this. Alan makes a really good point that based on this new study that came out about 2-3 months ago, you can wait a little bit to see which direction your PSA goes, and then you can jump in with radiation, but you still need right away a bone scan, and rather than getting into a discussion with the oncologist about what the right treatment is and this, that, and the other, somebody has to order this CT scan and the bone scan.
Mm-hmm.
And that'll also buy you enough time and will help navigate you to the right place, whether it is to a radiation oncologist, which might be correct, or if the oncologist is on his game, if it's somebody like Paul Korn, they're going to say, no, we think you should do this early salvage radiation. But let's wait a little bit and see which direction your PSA is heading. But the first step that you should do really is at least get a CT scan and a bone scan. I mean, the likelihood is they're going to show anything, but if they were to, it might change your treatment decisions.
Like I could message the urologist like tonight if you think I should him, or I could wait until Thursday and talk to the oncologist about it.
Either way, it's just important that you get it and you can get it locally, so you don't have to travel to MD Anderson for it. I mean, it's anyone could order it, and every hospital has the ability to give them.
Right. And Alan, just to fill you in, Tad is in Austin, and he had surgery locally in Austin. But
Yeah.
we're just saying, going forward, he may be better off to go to MD Anderson than staying where he is based on the way he's been treated to date. But I really, I do want to move on, only because we've got a lot of people that want to give updates today, and so I think we just, in the interest of time, we do need to move on. But you'll get an email from me tonight, Tad, and we'll follow up with you. The guys will follow up with you.
Thank you.
Peter, I didn't make enough time for you last time, and you have a significant update, and I apologize sincerely. And we're putting you on number one.
Okay, can you hear me without much static?
We can. What did you do?
I don't know, magic. Okay, so without going into all the history, this is my second round with recurrent disease. I did a gallium-68 almost 2 years ago, and Tad, I've been dealing with Gleason 9 that's spread outside the prostate. I've had surgery, I've had radiation, I've had more proton radiation for lymph nodes and stuff. I've been dealing with this for 6 years, and I plan on being around a long time more. And I'm a Gleason 9 from the get-go. Okay, so my PSA crept a little bit in September, and then it jumped 2 months later in November significantly. Again, remember, I don't have a prostate anymore, so it jumped from 0.13, I think, to 0.9 in a couple of months. And then the last one I had was it was 1.9 when I started Lupron. So I'm back on Lupron. I had a year off. Today, I called Bayer up today. They were supposed to deliver darolutamide, the Neblecquid, to me on Friday, but it never came. So I called them up, and I got the tracking number. It should have come to my house today, so I'll start that tomorrow if it did come. So I've got them on the 2-month trial for that, and we'll see where it goes from that. If my doctor can make a case to keep it up, we'll keep it up. If not, we'll switch to Alita or something else. I'd rather not go back on Zytiga, which I did most of 2018. So I'm still feeling strong, still feeling good. Lupron hasn't totally hit me yet, so I'm still working out at the gym and everything else. Only been 2 or 3 weeks so far. No bone mets. So I did a trial scan at Stanford of the PYL scan this time, and again my PSA was 1.03 when or 1.5 or whatever it was, maybe 1.8 when I did the scan, and it showed no bone mets. It did show more metastatic lymph nodes in my abdominal area, more than I could radiate to this time, so that's why I'm back on ADT. And then the other thing it picked up, which is a little bit of a mystery still, it showed what the radiologist called diffuse peritoneal implants. So it didn't label it as uptake of the PYL, so it might not be mets from prostate cancer, but it might be. We don't know. But it might be peritoneal cancer. It might be benign. I don't know. So my doctor, Turner, prostate oncology specialist, referred me to a specialist who's an oncological surgeon at St. John's up in Santa Monica, and I'm just trying to get through to them. I tried this morning. He was busy with surgery, so I'll try tomorrow morning. And if I need to fly over to LA next week or this week or whenever, I'll probably do an overnight procedure to get some to do a biopsy with laparoscopic surgery, and push for a quick turnaround on the pathology. Try to meet with Dr. Turner and come up with a game plan. If the results are not good and it looks like chemo's the way to go, I'll bite the bullet and do that. I'm not an ABC guy. I'm willing to do whatever it is. So say I've been managing this for 6 years. I think I can keep managing it. So that's the long and short story of it. I've still got a pretty positive attitude toward all this, and I'm not freaking out. And I'm looking forward to meeting with Ken here on Maui at the end of the week or next weekend or whatever. And yeah, all is good. So that's where I am. If there's any questions.
Well, I forgot to formally welcome Alan Edel, who's on our advisory board, and who is one of the most knowledgeable advocates across the board, as he's already shown us, and especially when it comes to matters of radiation. And I had written to Alan about Peter's situation to see what he knew about peritoneal implants. And I did forward your response to Peter, Alan, but would you like to share that with the group?
I don't know if I remember what I said. I mean, as I recall it, you said it showed up on the CT part, but not the PET scan. So
Right.
it wasn't PSMA avid, and so there were just growths on the peritoneum. So it sounds like what you're doing is fine. Just biopsy it, see what it is. It's probably benign, probably has nothing to do with prostate cancer. But that's the thing about whole body imaging. You never know what crazy thing is going to show up, and then you have to deal with it. Um, so I don't know that I have any good advice on that. I just, it sounds like you're doing the right thing.
I think you mentioned you ran across peritoneal implants once before, but they proved to be benign.
Yeah, that was my experience with one guy. I think they're usually benign.
Okay. Peter, that's good to hear, right?
Yeah, yeah. I mean, I think we're doing due diligence. We're going to explore, and I didn't trust. I didn't trust. I mean, this is for Tad's ears too. I live in Maui, Hawaii. 2,500 miles away from Los Angeles. I did not trust a surgeon here or a pathologist. I wanted to go back to California to do this exploration, even if it's just laparoscopic stuff. I want to go for the best. I mean, it's my life, it's my future. I want to be around a long time. So even if it turns out benign, it's still worth the flight for me.
What is the name of the surgeon you're going to see? Because Alan's fairly familiar with the LA doctors.
His name is Anton Bilchik, and he's in Santa Monica, associated with St. John's. He's got a great write-up. He sounds like a real expert in the field.
He's an interventional radiologist.
No, he's a surgical oncologist in Santa Monica, dealing with abdominal issues.
Oh, all right.
Oncology, abdominal issues.
But is he the one that's actually going to do the biopsy?
No, he won't. I don't think he'll read the biopsy. He'll do the procedure to collect the biopsy, and he'll look at my PYL scan to determine where to poke me, which I don't think anybody here in the islands is capable of doing. Yeah, I don't think anybody could read that kind of scan.
Well, remember, it didn't show up on your PYL. It showed up on the CT. So my experience is that has only been with a couple of interventional radiologists, they call them, who do sort of an in-bore biopsy in the CT machine. They do the biopsy while the patient is in the tube, so they're guided in real time. That's my experience. I don't know how. I'm sure this guy knows what he's doing, and he may do it a different.
I got the impression that that's the procedure I'm going to have, but I'll know more when the nurse talks to him and we come up with a game plan of whether I go this week or next week or whatever. I'm pretty sure that it's going to be a guided procedure, guided biopsy, because I have the scan with me, and I need to bring it with me.
Cool. Sounds good.
Okay. Anybody have any questions for Peter? Anyone else like to discuss the diagnosis with or the not the diagnosis, but the progression with Peter before we move on?
Yeah, Peter, this is Len. I was just wondering if Turner had an opinion on whether it was advisable to have the biopsy on what are likely non-metastatic prostate cancer growths, which they're calling implants. Did he have an opinion one way or another?
Yes, he for sure wants me to do this before
Okay.
we start talking about further treatment. He wants to know what's going on there in this region before we start talking chemo or anything else. That's that's the next step.
Okay, good.
Anybody else? And Alan, if you scan up to the top of the chat window, you'll find a terrific article and a very nice picture of Peter that was in the Maui news over the weekend. We put it in the chat window. So at the beginning of the meeting. So anyway, Peter, keep up the great work that you're doing. I mean, that was such a lovely article, and you deserve all the credit for it. So we're very pleased to push it out to a lot of folks. Okay.
Yeah. One more thing I'm going to quickly mention. Actually, I've already written it up for my announcement for next Monday's intermediate meeting.
Yeah.
Because I just had a buddy, Gleason 7 4+3, pass away this weekend, and he was a tough cookie. I could not push him or steer him toward radiation or any kind of treatment. He wanted to do his naturopathic stuff and his diet and his enemas and this and that, and it took his life. And it shouldn't have, but that's the way it went. So Gleason 7 4+3 can be just as deadly as a Gleason 9. That's my final word.
Was he ever on our call, Peter?
No, he'd been in my group, so I don't think he was ever on a call. He might have been when he first came on a couple of years ago, but I don't know.
You have a lot of those homeopathic guys on the island of Maui. It seems like.
Yeah, I know.
Well, thank you for supporting him, and we're all sorry for the loss.
I would just like to add, Peter, I hope you still have some hiking boots.
It's the energy I need.
Oh, maybe we can do a couple little hikes.
Okay, we'll figure it out.
I already told Ken that you're going to know all the good hikes on the whole of the island of Maui, based on your former on your former occupation, Mr. Kafka.
Yeah, I know them all, but we'll see.
Okay. All right, Len, tell us a little bit about your blood work.
Okay, so it's pretty good news for darolutamide, which means it's good news possibly for Peter as well, since he's about to begin darolutamide. I've been on it now 3 months. It brought my PSA down from 2.4 to 0.09, and for me, that's really good because after, like Peter, going on 6 years, Gleason 9, lymph node metastatic right from the get-go, my PSA never went that low, even after years of first-line hormone therapy and mega dose of radiation to the entire pelvic girdle. I never got below 0.11. So now I'm down to 0.09. And Peter, I don't think you're going to notice any difference in your energy level after you start taking darolutamide over and above what you already feel on Lupron.
Thanks for that great report, Len. Anybody have any questions for Len about darolutamide and his current treatment path?
Len, I have a question. For darolutamide, were you able to get it because all your metastases were pelvic, or how were you able to get darolutamide?
Yeah. According to my oncologist, Dr. William O. at Mount Sinai in New York, he said that the metastatic status applies to standard of care imaging, i.e., technetium bone scan. And I was negative for technetium bone scan both before and after my PYL scan at the NIH, where it showed several bone lesions.
Right, right.
Yeah.
And you're officially castration resistant.
I didn't catch that, Alan.
Are you officially castration resistant?
Oh, no, I don't think so, because when I first when my PSA, when my PYL bone scan came back positive, so I had been on drug holiday for about 28 months, and so when I started Lupron and Casodex, and my PSA already started going down. But then Dr. O was able to get the darolutamide for me, so we dropped the Casodex. And I only took Casodex for 2 weeks prior to Lupron.
Mm-hmm.
And so that alone had brought down my PSA. So I presume I would be considered castrate sensitive, even though I'm on darolutamide. I guess that's another, I don't know how in the world he got this thing approved, because it's not supposed to be approved for castrate sensitive.
But I've found that top oncologists somehow can get this stuff through insurance companies. I don't know how they do it. I don't know if they cook the book, but it's great that they do it. I'm very thrilled.
Yeah, that comment's true, Alan. That comment is true, Alan, because I know Paul Korn's last email to me stated that if I was having problems with enzalutamide, that he could switch me in some fashion to darolutamide, and I have meds.
Yeah, I don't know how they do it either, and it's a very pertinent observation, Alan, and it's always puzzled me. But the way we navigate folks who want to try and get onto some of these drugs, especially like darolutamide, is we say you've got to go to a really good GU medical oncologist because they have ways of getting these drugs. I will say that this technetium 99 workaround, though, does work. It is effective. I mean, if you have metastasis that shows up on a more refined scan like axiom and gallium, 18F, TCF-PYL, it may not necessarily show up on a technetium, and that's good enough for you still to be non-metastatic as far as the FDA is concerned.
True.
So we've actually been telling people quite often recently, if they have METs, but that's how it's been diagnosed with an improved scan, that they should also get a technetium scan they should ask for a technetium scan, because that might be able to get them onto darolutamide. Okay, well, I'm going to keep moving along here.
I'm curious how Peter got approved for darolutamide.
Peter? He may, okay, well, I can fill you in. He may have gone in. I think Peter may have. Oh, Peter, are you
I'm not
with us?
approved. I'm not approved. I'm on the 2-month free trial, and then we'll shoot for approval.
Oh, okay. And your doctor just applied for it and you got it?
We'll try for it. Yeah, we'll try our best. I don't know. I think I said that if we can't get on it, I'll switch to a leader or something. But I'm going to go for the 2-month free trial first.
Yeah, I mean, you know, Peter sees prostate oncology specialists in Marina Del Rey is his GU Medonc, and they also have the ability to pull rabbits out of hats. So don't know. I mean, these guys can do it. We don't ask the questions, but they can do it. We've seen it. So, okay. Anybody else have anything for Len? Or for Peter, for that matter. Okay. All right. I'm moving along to Joe Blanchette. Welcome,
Yes,
Joe. Happy New Year.
I left you last Monday with having declined the Xofigo SBRT clinical trial at Johns Hopkins. And the next day I had an appointment with a radiation oncologist here in Virginia. And I went to see him. He says, well, I agree with your GU medical oncologist that all you need at this point is radiation. And he says, SBRT is the way to go. Depending on my planning, you'll need either 1 day of radiation, 3 days, or 5 days of radiation. But he didn't know at that point because he hadn't planned my radiation yet. He says, even though Johns Hopkins was going to do CyberKnife on you, I'm not going to do CyberKnife on you. But I'm going to do Tru-beam. He says Tru-beam is better for static bones, like the iliac bone, which is where my cancer is, as opposed to organs. The CyberKnife is better for that. It's a matter of using X-rays as opposed to CT for placement of the radiation, I guess. And so I then he gave me an order for an MRI so he could do the planning. So I'm going to do an MRI this coming Friday and for the purpose of planning his radiation. I then wrote back to via my chart to Dr. Antonarakis, and basically I'm going to read to you exactly what his reply was. It says, thanks, I read both of your messages. I fully concur to proceed with SBRT alone, and I'm very comfortable with Tru-beam and Dr. Eblin. Please pursue this option with my full blessing. And then I had asked him a question about Foundation Medicine because he had ordered a 386 gene test from Foundation Medicine back on 1 October. And he said, your Foundation Medicine DNA analysis showed mutations in the P10 and the TP53 genes. Cancers with combined mutations in TP53 and P10 appear to be more sensitive to various forms of radiation therapy. So this finding also supports the notion of swiftly pursuing SBRT as the next step. At this time, I do not believe that a new somatic DNA analysis of the recent bone biopsy would add additional information. So I'd asked him if I should get one of the 3 samples of the bone biopsy that NIH took out of me for further somatic testing, and that was his answer. There was no further reason to do anything else at this time. So basically, that's where I am. And on Friday, I go for my MRI, and then he's going to bring me back in for an hour and make a mold of my body so that the radiation can go in the right place. And then I guess that I'd never heard of that, but I guess that's standard operating procedure. And then he's going to radiate me. and as soon as possible.
I want to go to Alan because there's no one I know that knows more in the lay field about radiation than Alan. But before we do that, I just want to ask you, do you have a copy of your Foundation Medicine report?
No,
Joel?
I do not. I don't even have a copy of my bone scan results yet, which were all 3 bone samples were positive for prostate cancer, but I need to get that out of NIH. Their records, people are very slow at delivering reports. But
what about the FMI report? Was that done by NIH? Was that submitted from NIH or from somewhere else?
What's an FMI report? I lost you.
The Foundation Medicine.
Oh, no, that was directed from Foundation Medicine to Dr. Antonarakis. So I haven't seen the report, but I can ask for it.
Yeah, do get a copy of that report. It's good to have in your files, and there may be some other information in it. You know, when Professor Bill, God rest his soul, was with us, we used to like to send them to Bill for him to cast his eyes over. Unfortunately, we can't do that any longer. But having said that, I would definitely recommend you have copies of all your reports in your files, especially the FMI. P10 and TP53 are pretty common. We see that often in men with metastatic prostate cancer. Whilst they do make you sensitive to radiation, they're not actionable that we know of as yet with any other drugs. But there's stuff going on right now. I read something recently about, and I can't even remember what it was, but it did mention that it could address TP53, but it's nothing that's available at this point in time.
Yeah. Yeah, go ahead.
So that's all I was going to say, but I just want to encourage you to get a copy of that FMI report. Alan, what's your take on the Tru-beam? I should just add that Joel is not doing any hormone therapy right now, and the reason they took the core samples from the iliac crest at NIH was because they were trying to ascertain that he did not, that it was prostate cancer and not Paget's disease. Right. And so they did ascertain that it was prostate cancer. And the decision that Antonarakis recommended was to hold off on the hormone therapy, but to do spot radiation on the iliac crest. And they tried to, not Dr. Antonarakis, but one of the other radoncs tried to run Joel into a trial that really wasn't that appropriate. Unfortunately, that didn't proceed, so that's why he's local. And you heard the rest today, the update on the Tru-beam. So I'm just curious for your thoughts.
Just one more issue. If you remember, you had a question, Rick, last time I talked last Monday about Antonarakis saying the lack of ADT was a me thing. And I had a question about it too, and I said, well, next time I see him, I'll ask him about it. But there was a video that I found on the internet between Alicia Morgans and Antonarakis about a clinical trial he's doing on rucaparib. And basically he said in that video, he says, my interest is curing cancer as much as possible, all prostate cancer, or at least subsets of prostate cancer, based on the genome, and using for right now the PARP inhibitors and the immunotherapy drugs. And he says, we've been doing ADT for 70 years. There's got to be something better. So his interest right now is, you sent me over there, Rick, and I appreciate it because that was a good recommendation, I thought, because I sort of fell in his lap because he felt I didn't need ADT. And so that's why he's stressing no ADT and cures the other two modes.
Okay.
And so I just want to explain that to you, that I found the answer to that.
All right. So my prostate cancer was treated when it was localized with Tru-beam with rapid arc. So I'm a big fan of Tru-beam. It's definitely fast. I would say each treatment took between 5 and 10 minutes, and most of that was setup time. It was very fast, painless. The treatment itself is nothing. Um, do you know what kind of dose, how many treatments, and what kind of dose? I think you said anywhere between 1 and 3 treatments, but at what dose?
No, he didn't give me the dose. He said he won't know the dose until the planning, but he said it would definitely be either 1 treatment, 3 treatments, or 5 treatments. But until he sees the MRI and sees where all my organs are, he says the only danger you have is that you get your left leg with neuropathy in it, or I damage your intestines, and that's the worst case. And he says I don't want to do that, so I'm going to plan this carefully.
Yeah, pelvic bone mets usually does not entail many side effects. It's pretty straightforward. Um, I I didn't really understand why you were saying with metastases why you're not using ADT.
Because my GU med-onc at Johns Hopkins is saying, don't use ADT right now. You don't need to. You only have one spot of cancer. I had 4 scans. I had a CT scan, a FDG scan, a sodium fluoride scan, and a PSMA PET scan, and they all said the same thing. They all pointed to the left iliac bone only, no soft tissue involvement whatsoever.
Yeah, that's all that's visible.
Yes, yes.
Right? Yeah, yeah, obviously. But what about all the cancer that is invisible, that you can't see?
So
That
we'll have to
ADT
catch
is
that at a later
cool.
date.
What?
We'll have to catch that at a later date, I guess. I do expect the cancer to come back in some other bone or some other place, but hopefully we'll have even a better scan to the PET scan by then, and we'll catch you
Well,
earlier.
yeah, but the whole idea of early ADT, and this has been a whole shift in thinking to treat earlier with as much heavy hormone therapy as possible. Like you heard Len say, he's getting darolutamide
Right.
plus ADT. There have been studies that have said ADT plus enzalutamide plus abiraterone plus you name it. What it does is it increases survival more when used earlier. If you wait longer, it just doesn't work as well. So the idea is to hit it heavy early on to treat what you cannot see as well as what you can see. I I have absolutely no issue with radiation to the Mets. You can see why not go after them. But I've got to say, there's not convincing evidence that it accomplishes anything. What does accomplish something, is, and we know it does, is heavy hormone therapy as early as possible.
Okay, I appreciate that point of view. I understand it, and I think Rick would totally back you up on that. But right now, I'm going to go with my geo-oncologist, the medical oncologist, because I've only started with him back in October, and he's impressive to me anyway, so far.
All right, good luck with that.
Yeah, yeah, thank you.
Yeah, I think if it was me, from what I've seen, I probably would be adding ADT, but I have a lot of respect for Antonarakis. He's a very good GU medonc, very well published. I don't really get it, like Alan. I'm not sure on what basis he's doing it. What I will say is that I suspect that he's kind of holding off on a short-term basis, and that he won't be reluctant to prescribe it when it's needed. But if he can keep you off of it for a little bit longer, that's probably his plan. But I don't really understand it either, Joe. But we'll keep you on the straight and narrow here. You know that.
Yeah, well, I appreciate everything you've done for me, so I really respect you.
Rick, while we're having this discussion, there's a guy at Johns Hopkins. His name is Phuoc Tran. I hope I'm pronouncing this
He's
right.
a radiation oncologist that tried to put me in the Xofigo clinical trial.
Yeah, he's the one that just did a study on oligometastatic prostate cancer, treatment of metastases. What he found is that progression-free survival is delayed by radiation treatment of metastases. However, he didn't show that survival is increased. My opinion is when you treat metastases like this, you're treating PSA, you're not treating the cancer. So PSA is a biomarker that we use when you have a metastasis. Those metastases put out a lot of PSA. Most of the PSA they detect in your serum is due to the visible metastases because they have leaky blood supplies that bring the PSA out from the cancer into your blood. When you get rid of them, you still have the cancer, you just don't have the PSA. So when people say that they've been able to put off treatment because of metastasis-directed treatment, it makes me very nervous because I know there's cancer there. There has to be, because how did the cancer get to the bone in the first place? It has to be circulating in the blood. There's just there are millions of cancer cells floating around. So just treating, it's like treating the tip of the iceberg without trying to melt the whole iceberg. It would just make me very nervous to do that and to delay ADT based on the fact that you're then not showing PSA because your PSA falls undetectable afterwards and you delay ADT because of it. It worries me that it's impacting survival because you're giving all that prostate cancer a chance to grow in the tissue where it's already landed.
Yeah, I don't disagree with you at all, Alan. I mean, I've always been skeptical about radiating oligometastasis. I mean, for me, and I've said it on this call many times, that the real use for me for spot radiation is palliative, and that when men have pain, it's a great use. But I don't see it as a curative or management tool. But it is favored, and that's. I can only say what I would do, and you can only say what you would do. I was not that impressed with the way Dr. Tran handled Joel's request for radiation. I will say that. You can listen to the last call to hear more about that. But and I'm very impressed that Antanarakis backed up Joel 100%. That's a real plus for me. But anyway, thank you for saying that, Joel. Just remember, advice is worth what you pay for it, right?
I appreciate you guys saying what you said, and keep that in mind. And maybe ADT is in my future real soon.
Okay. Okay. Well, you know, as a peer of mine in terms of advocacy, I don't think there's anybody that gives better support navigation than Alan. So we'll just leave it at that. And anybody want to ask any questions to Joel about his treatment choices? Anybody else? Because this is a pretty radical treatment choice. Anybody have any questions to him, Peter, or anybody else?
I would just like to make the comment. What's the bank that advertises "Don't leave home without it"? You know, don't get a scan or procedure or anything without getting your discs and so forth. You know, I got mine right away at Stanford. I only had to wait 10 minutes. Same thing with UCSF. They burned the CDs right away, so I left with them. And I got the reports pretty quick. So, I mean, it's our responsibility to be our advocate and carry this stuff with us. So don't rely on the doctors to hand you stuff.
Yeah, I have all of my discs of all my last 4 scans and previous scans also.
Okay. Anyone else before we move on? Now, let me just check. We've got a visit with Jerry, Dennis McGuire, and Jim Kubat. Do any of you guys have to get off quickly? Or can we take you in turn? I don't want to lose any of you, especially Mr. Kubat, because that happens occasionally.
Well, if you don't get to me, I can wait until next time.
Well, we'll come to you first, since I know your habits, and the other guys I'm sure will forgive that. So Jim, tell us what's going on and give us an update, and what's your question?
Okay, so here's the update very quickly. August of 17, I had a radical prostatectomy. By the following May, my PSA started to double, so that by that following October of 18, a radiation oncologist, James Yu at Smilow Cancer Center at Yale, said there was an 80 to 90% chance I had a recurrence. And he recommended both ADT treatment and radiation. So that's what I did. I had 6 months of Eligard, and right before that, I had bicalutamide for 30 days, and then I started radiation in mid-December and finished in early February. I had a follow-up PSA last June, and it was less than 0.008.
Right.
Then I had another PSA, I think it was September, and it was less than 0.008. And then in December, when I saw Dr. Yu again, I had another PSA, and that was less than 0.008. And I asked the resident, well, what would that mean? What would I consider my status to be? Am I in remission, or what do they call it? And she said, we'd call it that there's no evidence of disease. So I met with Dr. Yu, and he said, I don't need to see you for another year, and you'll have a PSA in another 6 months. So that'll be this coming June. And I said, well, every 6 months, is that a little risky, considering that the last time my PSA was doubling every 3 months? And he said, well, at this point, we wouldn't consider doing anything for you if your PSA was going up until it hit a 10. So that would be from less than 0.008 to 10.0, because I wanted to make sure I understood what he meant by a 10. And he said it's an actual 10. So I just wanted to run that by you. If you guys are okay with my just sitting on it like that, I'm fine. But I just wanted to see what your opinions were about what he said.
Who wants to kick that one off?
I'll jump in.
Alan, go ahead, Alan.
Well, James, you
Quiet.
is the best. So congratulations on using him. Also, when you said what you're telling us is that you have undetectable PSA, that less than just means it's undetectable.
Right.
And I assume that your testosterone levels have come back up. Is that correct?
Yeah, that's correct. They were at their lowest. They went to 18. And then the next test I had, it went to 308, and now it's up to 364.
Wonderful. So I can see why he's saying you can wait a while before having your next PSA. You've had a string of very good undetectable PSAs. There's every reason to believe they got it all. 6 months seems very reasonable, or a year, even at this point, seems very reasonable. Why create more anxiety than you have? You know, as to what you would do about it and at what point you would do about it, deal with that when you get there. Right now, you should be celebrating and drinking champagne and saying, "Hey, this is great. As far as I know, I've beat this thing." And you still have to be vigilant, but it looks really good.
Fantastic. Thanks for the
Len,
comment.
do you have an opinion on this? I think Len may have stepped out for a while.
No,
so
sorry, Rick. No, I'm
He's
here. Sorry, I didn't realize you called me. I was just curious, what is Jim's Gleason score?
At the time after surgery, they determined it was a 3+4.
Oh yeah, you're going to die of something else, not prostate cancer.
Good to know.
Yeah, that you're low intermediate risk to begin with, so you're in good shape.
Well, I might disagree a little bit with these guys. I mean, first of all, I think in the year going on, but you know, I also recognize, Jim, that you get yourself in the tears fairly easily.
Yeah,
So on that is to argue to go for a PSA after 6 months. If it were me, I probably would get one every 3 months, at least for the first year. But I think that you can safely wait 6 months if it's not going to bother you. As far as when to intervene, I mean, Alan's right. It's not something we have to address until we know what the pattern of your PSA is. So if your PSA stays like this, we don't even have to worry. I would say that most GU med-oncs, I mean, Chu is a radiation oncologist and not a GU med-onc, but I would say most would probably intervene somewhere between 5 and 10. I don't see too many waiting until 10 anymore. that was true maybe 10 years ago. I would see it and it would be often discussed. It seems like earlier intervention makes more sense, much for the reason that Alan laid out earlier on. I don't know if anybody here has got direct experience of when they intervened with, if their disease came back after radiation. Peter, when did they intervene for you? They
intervened with me at around 2, but it's not an accurate thing because my doubling time was substantially more. So it was you know I'm a Gleason 9 to begin with, so
right.
it's not a fair comparison.
Right, and I think that's exactly what Alan is saying, that it's not just an absolute number. We need to see that pattern. I mean, if you double very quickly, I mean, God forbid, in 6 months' time, you wait 6 months, and God forbid, at that point, you've gone from 0.08 to 1.0, we're going to say, okay, let's test you next month and see where it goes and then decide.
Yep.
So, you know, it's not good advice, it's not bad advice, it's basically saying, let's not cross the bridge. 10 is saying, let's not cross a bridge until we come to it.
Right. Sounds great, guys. Thank you.
Our pleasure. Anybody else have anything to say to Jim? Okay. So let's go to Jerry Pelfrey, because hopefully that will be quite quick, and then finish off with Dennis. Jerry, how did your treatment pan out?
It was quite nice, really. I had 20 treatments of proton pencil beam at Mayo Phoenix, and there was nothing to it. Now, of course, just like you all know, some side effects will show up later. They don't show up right away sometimes, but as far as any side effects for me, they didn't hit until the 19th treatment, and it was the fatigue that hit. And so I'm just now kind of getting out of that fatigue stage. I'm still a little fatigued, but everything went all right. And if all I get is just this fatigue, I'm fine. My PSA has been 0.1 for the last 3 times, and Dr. Singh at Mayo, as I think you guys know, they stop at 0.1. They don't take it below that. So I'm now, as Dr. Singh said, I'll see you in 3 months if you call me and tell me you've got a problem. If you don't have a problem, reschedule for another 3 months and I'll see you in 6 months. So I'm really quite pleased, considering, as you guys know, my original PSA was 3,193, and that was last February 6th. And so I'm still here, and you know, I'm working out, trying to make sure that I can keep my spine, at least from a muscle standpoint, somewhat safe, since I have Mets from the bottom of my spine to the top, and a couple of spots along the shoulders and a couple in the ribs, but I don't have them now, obviously, but that's how it started out. So I'm still on Lupron and Zytiga, and I'm hormone sensitive, and Singh says I'll be on ADT until I guess I get resistant. And so now it's just a wait and see. So that's where I'm at.
Well, I mean, that's basically a very good report. Let me ask you a quick question. Were you exercising throughout your pencil beam 20 treatments every day?
No.
No. Well, my own personal experience was that when I went through my IMRT part of my treatment, I did exercise every day. I probably missed maybe 2 sessions. And when I couldn't do anything else, I just went out and walked for half an hour or so. And
Yeah, that's all I've been able to do is just kind of walk around the block where we are.
Right. But were you doing that daily throughout?
No, not really. But that's more because the schedule was all off. I was going in the morning. I was going in the afternoon. A couple of times I was going at 7:30 at night. They had one of their machines. Well, they had 2 of the 4 machines go down, and they got the 3rd one up, but the 4th one took a while.
Well,
so
whatever the reason, I do think it is so important to try and exercise right the way through your radiation. I do think it makes a huge difference. Having said that, I mean, I'm really delighted to hear that that you had no other side effects, because you were getting radiation to your pelvic girdle and to your prostate, isn't that right?
No, just the prostate.
Oh, just the prostate, not the pelvic
Just
girdle.
the prostate.
Okay.
Yeah.
So
and I was getting, I think it was 2.5, a total of 5 for every treatment.
Now you're getting into Alan's field, and I get a little. I don't do so well with the grays, as Alan knows. I can't even figure out my own grays, so I think I got them confused. But I want to ask Ken Anderson, when you had your radiation, was it just to the prostate, or was it to the pelvic girdle and the prostate?
Yeah, it was actually to both. But I also wanted to state, the house that you're renting, Jerry, it's got the community itself has an incredible health club. I mean, and it's open for you to use. It's got all the equipment you can imagine.
Well, a little late now, but I'll tell you something. I'll talk to you offline, Ken, about that.
Okay. But anyway, yeah, I did in fact have the girdle radiation and the prostate. They didn't go up very high. So, and I'm pretty confident because as you know, I went in and had a biopsy done because it looked like there was some additional cancer in it, but they found in fact that it was inflammation. So anyway.
Well, I mean, Jerry, I just want to say, I mean, I'm thinking back to a year ago and you and Debbie, and I think this is a fantastic outcome where we are. And by the way, I love the picture that you sent to us, and thank you to me, and thank you so much for sending that picture.
I'm still wearing microsage on my jacket.
Oh, okay.
Well, I figure we've got to promote the prostate cancer and the research like they do breast cancer. And so I just wear it. And when anyone asks me, I tell them it's blue and it's a corsage for prostate cancer. The more marketing we can do, the better.
Debbie made up blue corsages for all the family. Was it at Thanksgiving? Was it your Thanksgiving dinner? Yeah.
Yeah, it was at Thanksgiving.
Yeah. I'm just happy you are where you are today, and I know
you're not as happy as I am.
Yeah, not as happy as you are. Well, it's great news. Anybody? Does anybody have any questions that they would like to ask Jerry, about his treatment, his side effects, anything else?
I have a question. So
Yes.
they use protons on your prostate while you had multiple metastases in your spine. So the purpose of the prostate radiation was was preventative. I guess I'm asking a question. Was it preventative to prevent prostate problems down the line?
There was never a question that we were not going to do that because we did want to stop any possibility of any testosterone again because of the extent of my metastasis, I guess you might say.
Yeah, I guess I'm asking, why did you have the prostate radiated?
So let me
To
jump a little bit, and Jerry, you can add. We are seeing more and more a movement with amongst the good GU medoncs to debulk the primary. Sometimes with surgery, we've got a couple of guys who have done surgery who were diagnosed metastatic. More often with radiation. I can think of 3 guys, maybe 4 in the last year, who have gone through debulking. Some just the gland, and others, like you heard from Ken, the gland and the pelvic girdle. But it's just becoming a lot more prevalent that they find it's important to debulk the primary.
Yeah, the question, I guess, is what is your expectation of doing that? The Stampede showed that there's no survival benefit in debulking the primary once there are multiple Mets. However, there is a future palliative benefit because the prostate, if left cancerous, will eventually start causing you problems. You'll get bleeding and you'll get retention and all kinds of problems just because you have cancer still in the prostate, and radiation to the prostate is a good way of preventing those kinds of problems.
right.
So it's really just a matter of what you expected to occur as a result of it. And my other question was, why didn't you, while you were at the proton facility, why didn't you have them do your spine for pain palliate, to prevent spinal
Well,
compression?
actually,
Yeah.
Alan, I'm lucky. I don't, my pain was between my shoulder blades from about T4 to T6. I have a collapsed T5 and I have a fractured C2. And Dr. Shields, my RO, did do palliative for me. And we used photon, not proton. And we did that. That was pretty much, within the first 2 or 3 months of treatment back in the spring. So I have had that done, but it was done quite early.
Yep. Sounds good.
Yeah,
Yeah,
Alan, we have a member of our group who had an untreated prostate cancer, untreated prostate gland even though he was on ADT and he had metastases, and the cancer in the prostate gland invaded the urethra, and then he had to have at least a temporary urostomy. So that speaks to what you were talking about, I think. Why the reason why eventually they did debulk his prostate gland
Yeah,
for
it
that
makes
reason.
a lot of sense to me.
Yeah, and then there's something else which is pretty esoteric, but I think Len and I have seen this article recently. Len, I can't even remember where we read this, but this whole idea of the metastatic prostate cells actually circulating back to the prostate, finding their way back to the prostate when they get into the bloodstream, and then tainting the cells that are actually in the prostate, the
That was-
live cells that are in the prostate, so that the iterative process.
That was Ken Pienta at John Hopkins been saying that.
Thank you. Yeah. So, that's puts a stop to that iteration. In the interest of time, I do want to move on because we still have to talk to Dennis, who's our last stop today. So, and Jerry, I'll call you tomorrow and we'll try and figure out a time to meet up when you're down here.
Oh, okay.
Okay,
Sure.
where are you staying? Where are you going to be staying?
Let's see, in Tucson, out on about 65th and Speedway.
Okay.
I think it's like 6477 Speedway.
Okay, fine. All right. Well, we'll talk. Maybe we'll even pull Dennis Correa in. He's not on the call tonight, but I'll talk to you in the next couple of days, and we'll figure out a place to meet. Dennis
Sure.
McGuire.
Anywhere in Tucson's fine. We've been all
Okay.
over there, so.
I'll call you. I'll call you.
All right.
Dennis McGuire, thank you for your patience.
Sure. Thanks, Rick. Yeah, quick update. So I had a biopsy of my pelvic lymph node at Sloan Kettering in November. Initial results came back that yes, it is prostate cancer, not inflammation. I'm still waiting on the sequencing. I'm expecting that to come in any day. The plan is once we see that, we'll take some action. I've been on Xtandi for close to 2 years, and it started failing about 6 months ago. And my PSA has risen to 10. There's been some preliminary talk of a clinical trial, lutetium. And to the earlier point about debulking, there's been talk of radiation of the prostate and pelvic lymph nodes. But I think definitive next step will come once we see the complete sequencing.
Right. So, what was it that you mentioned? The lymph nodes were biopsied. Which and you did say which lymph nodes. I just didn't catch it.
Yeah, the pelvic. I guess it's the iliac.
Okay. And where did they send it for sequencing?
Sloan Kettering, where I had the procedure done.
Okay. So it's being sequenced at MSKCC.
Right.
Okay. And so this is with Morris, right?
Yes.
Okay. How do you like Morris? How do you find him?
Very, very smart guy. I think he's on top of his game. takes a while to get to know him on a personal level.
Mm-hmm. Yeah, I mean, he certainly has the reputation. We've found some people get on with him really well and others don't. It may be this issue about just being with him for a good period of time.
Yeah. I've been with him 4 years.
Yeah. I mean, how long was Dom, God rest his soul, with him?
Maybe 2 or 3 years.
Yeah.
But then, he got annoyed with Dominic when Dominic went down to Dautoli in Sarasota and got some radiation when Morris advised against it. And he kind of made Dom feel like he was unwelcomed after that. So that was the end of that relationship.
Yeah, that's right. Thank you for reminding me. I was trying to remember what the glitch was there. Now I remember. I agree with you, Dennis, that the next key step is to see the results of the sequencing. And, hopefully they'll share that with you and you'll share it with us, and then we can navigate you as best as we can. Clearly, the lutetium-177 has proved to be a good option for a lot of guys, and the earlier you get it, the better it is. I think Alan may have something to say about that. Debulking the primary, we've talked about already today. But I'm glad that you are, you're moving right along. How are you managing this Wisconsin, New York axis?
So far, it's been okay. We haven't had to make any decisions. I think we'll find out how that dynamic works when we make a decision on the sequencing. If we can have consensus, if there's difference of opinions. For example, I don't believe Morris believes in debulking the primary.
Mm-hmm.
Because he's never brought it up as an option.
Yeah, but they did a clinical trial with debulking the primary surgically about 5 years ago, and they came out with good results, but they reported pretty quickly, and that was an issue with those results. But
if I may interrupt, it was in Stampede, they did it with radiation in the oligometastatic setting, and they found there was a benefit.
Yeah, and you might press him if you get any pushback, Dennis. Press him on the study that Memorial Sloan Kettering did on debulking the primary, the surgical one. So there's a couple. There's the Stampede that Alan cites, and there's the surgical one. I mean, I think the problem was they found really good results in the surgical one, but they reported like after 20 or 22 months or something like that. I have the study linked somewhere and I'll send it to you. So it was really too early to, that was the criticism of the study. And I don't know that they've reported since then. Alan, do you know what I'm talking? Do you know the study I'm talking about?
The only randomized trials I'm aware of was so far that's reported was with radiation at Stampede, and there was the HORAD trial, HORRAD, in I guess that was in the Netherlands, that found there was no benefit, but they didn't stratify it on oligometastatic versus lots of metastases.
I'm going to put something in the chat window, but I can't vouch for it. because I need to look at it again, but I think this is the one. I think this is the one that I'm thinking of. I'm putting it in the chat window right now. And I'm sending it out to everyone. But I think this might have been the Memorial Sloan Kettering one, but I'm not sure. I'll look for it when I've got more time after the meeting. One thing I did want to say to you, and I've mentioned it before, Dennis, Madison just last year became an NCCN hospital. And my memory is that they do some good stuff with prostate cancer. I can get a name for you from Chuck Ryan because he's always been pretty close to the guys at Wisconsin, at the University of Wisconsin Hospital in Madison. So if you need that, you'll let me know when the time is right, and I can hopefully come up with a name for you at Madison.
Okay.
Is Madison far from where you are in Wisconsin?
No, it's like 30 miles, so it's very easy.
Perfect.
And one thing I've noticed with my visits to Madison, it's a very collaborative hospital. When decisions are made for patients, they take it to a board and discuss. So it's really not, you're not with one oncologist, you're with the whole team.
Yeah, we have one guy who's treated there, and I can look up his name. I can look up his name and his I'll send it you. I'll send you his name. I'll connect you. And he's been seeing a good geomed on there for a long time. So I will. I'm just making a note to connect you. I think we need to stop because people are dropping off like they're dropping dead like flies here, and there won't be any of us left other than the four of us who are looking at each other before too long. So a couple of things. One is that Ken is running his group for men under 60 with advanced prostate cancer on Thursday. And I know Jim Ward just dropped off, but hopefully he'll be there. And Ken will be there. And Dennis, you're very welcome to join us in that group. I don't know what Ken is going to be talking about. I think we tend to talk less about treatment, but it isn't ruled out. It's really more to give support to all of you younger guys who sometimes feel that you get lost in the shuffle when amongst the old farts. So don't forget that on Thursday at 8 o'clock Eastern. The other thing I wanted to mention is that we try to get into the habit of posting the links that we put in the chat window on our prostate cancer forum on our website. So if you're on the phone and you're anxious to see any of these links, then please take a look. You'll have to log into the prostate cancer forum. There's a login button on the top right of the homepage, and you'll find the links there. Other than that, I just do want to wish everybody on this call and anybody who listens in a very happy and a very healthy new year. We hope to be talking to you guys as frequently as you need to talk to us. Okay?
Thanks, Rick.
Special
Thank
thanks
you.
to Alan and Dell. Thanks so much
Happy
for
New
joining
Year.
us, Alan. Very
Yeah,
enlightening as always.
You were a big help, Alan. Thank you.
Thank you. And our next meeting is Tuesday. Hold on a minute. No, wait a minute. I'm looking in December. That's not going to work. Yes, Tuesday the 14th. Yes, I've got to get a new calendar. Anybody got any extra calendars? I need a couple of calendars. I got to go out and buy them. All right. Talk to you all very soon, and have a good week. Goodbye. Good night,
Good night.
everybody.
Right.